opportunity to speak with all of you today. I have no disclosures. I'd just like to get my audience information so I can make my remarks more cogent to you. How many of you all have out lesbian patients in your practice? Great, that's probably about 90%. How many of you all think that lesbians smoke at a higher rate than heterosexual women? Maybe 10%. How many of you think, how many of you all think that lesbian women have a higher rate of sexual dysfunction than heterosexual women? About 2%. And who thinks lesbians need pap smears as frequently as heterosexual women? About 50%. Okay, we'll address some of these issues. First of all, it's actually quite hard to define who is a lesbian. It depends on the methodology, but pretty much about 1 to 5% of the female population is lesbian. And unlike the AIDS epidemic studies where it became very important to actually look at behavior rather than identity and studying the transmission of HIV, for lesbian health research, most of the studies are on self-identified lesbians, which is a little confusing because when you actually ask about sexual behavior, you find that 70% are sexually active with women only, and 30% are sexually active with women and men, which then technically puts them into a bisexual category. And when you look at the whole LGBTQSI spectrum, you have quite a variety of sexual practices and prevalence of choices of sexual partners. So just keep this in mind. And in fact, when you look at that umbrella, actually we have more bi women and men than any other single category. There's lots of diversity among lesbians, ethnic, age, educational level, income. Now, lesbians tend to cluster in urban areas, but there's certainly lesbians in rural areas. And through the research of Audrey Coe in San Francisco, with some of her private practice surveys, we actually find that bisexual women have increased health risks as well as lesbian women with a delay in obtaining screening tests such as mammograms and cholesterol screening and in mental health issues. And this is an area that needs much more research. Diamond is the expert in the fluidity of women's sexual attractions, sexual behavior, and it's important to recognize that it can change over time. She followed a cohort of youth who 10 years before the end of the study had identified as 38 lesbian, 27 bisexual, 24 unlabeled. And certainly youth today do not like to be labeled in categories, so that's also very important to keep in mind. And then after 10 years, 67% of this group have changed identities. So sometimes when you are seeing a patient who may have been bisexual the year before, you may want to ask, and what is your sexual activity included this year? The majority of lesbians want you to know that they're lesbian, but they're unlikely to disclose spontaneously. So that puts you in a challenging situation. And so how can you get the trust level up so that lesbians actually come out to you as their provider? Or having inclusive forms rather than just married or single on your forms. You should, put partner, domestic partner, etc. And in those states, of course, who have same-sex marriage, now it's a little more complicated if marriage is large. So you really just need to ask that old basic question, are you sexually active with men, women, both, or neither, so that you can really know what sexual relationships may be happening. I think that disclosure is very important. I'm going to tell you a story that happened last year when I was attending on service, and there was a lesbian with twins who had come in for epigastric pain. Her blood pressure was normal. She came on rounds, came out that her platelets were low. I go and see her, and she's like in a pre-seizure state, has HELLP syndrome, but didn't have the elevated blood pressure. We need to get to the operating room because the twins are having late decelerations and her same-sex partner's there. And I'm thinking, she has to have general anesthesia, she has thrombocytopenia. What if she doesn't wake up? Who's going to make decisions for her? Who's going to make decisions for the baby? And I started exploring this because in California we did have same-sex marriage for 4 months and now we don't have it anymore. But her partner was a physician on staff and she said, don't worry, I'm her health power of attorney. We actually got married during that 4 months, so I could actually get her to the OR 5 minutes sooner than I could have if that hadn't happened, as I tried to get the form straightened away so that if things did not go well in the OR, we would know who was going to be making decisions. So anytime I actually have a same-sex couple I actually try to have their power of health attorneys forms either scanned in to the electronic medical record or with their paper chart if they have a paper chart, just so that I'm prepared as their physician. I'm going to take us through the life cycle of lesbians and tell you what we know about this emerging field, because it's been very hard to actually do evidence-based research until the last 10 years because the federal government was not willing to fund. The Lesbian Physician Conference started a lesbian health fund, which has now funded about $500,000 worth of pilot projects, some of which have gotten to the level of the NIH. But all of us here after this hour will be more expert on lesbian health than the majority of clinicians. And I encourage you to share this information with your colleagues and to share stories with me and with others about what your observations have been about your lesbian patients. There is more childhood abuse of lesbians, increased sexual abuse compared to heterosexual youth. The relative risk is about 5.3 for bisexual women, 3.4 for lesbian women compared to heterosexual women overall. But of course, childhood sexual abuse is an epidemic in our country with an overall rate of 14.9%. There's an increased risk of psychological abuse as well as physical abuse at home, and we're not sure why that is. Is it because parents are noticing some gender variance, something different they're trying to rein in their kids? We're not sure. As kids get toward 11 and 12, no matter what their destiny is in terms of choice of relationship later on, people need HPV vaccine. Now it's being pushed for boys as well as girls. And through the work of Jeannie Mazerow at University of Washington, Seattle, we know that HPV does go back and forth between lesbians. This has actually been proven now with PCR. Lesbians get very upset when they're diagnosed with STIs because they don't expect to be able to be at risk of STIs, since they often usually are not having sex with men. So that also requires some sensitivity on your part as a clinician. If you have a lesbian who is diagnosed with an STI, she may be rather shocked. Alcoholism is a problem in the lesbian community, and in fact, heavy drinking is initiated earlier compared to heterosexual female youth. This statistic always shocks me. Sexual assault has also increased in lesbian youth, and this is related to alcohol and for judgment, high-risk situations, we're not sure. This is some of the most important research I think that has been done in the last decade in lesbian health, and it's by Caitlin Ryan, who's out at San Francisco State. And she published in the Journal of Pediatrics about 2 years ago the effect of an accepting family on health outcomes in LGBT youth. And you can see here that with accepting families, the rate of depression goes from 63% down to 24%, substance use problems down, unprotected sex and thus HIV down. And these are typical rejecting behaviors by family when their teenager comes out, banning or removing LGBT decorations in the bedroom, telling her she'll grow out of it, denying that disclosure was ever made. And this is not uncommonly shared with me by young women that I told my mother I was a lesbian, but she denies I ever had that conversation with her. Selective hearing from the parent, sounds like. Asking her to keep her identity a secret when she does come out, especially from family friends, banning her friends and partner from the home, telling her that she's doomed, and asking her not to come to family events. Now, accepting behaviors, allowing decorations of posters, if she does disclose, showing infection afterwards. And what the Family Acceptance Project does, it works with Mormon families and families from our Central Valley in California, where there's very conservative families, and helps the family get language to understand what the youth is going through. These families, although they are judgmental and rejecting, they love their children and they want to do the best they can within their sphere. And so what this project does, it really just helps them give language and support. Another accepting behavior supporting efforts to fight LGBT discrimination, which of course is extremely common in middle school and high school. There's a lot of bullying and stigmatization going on. Advocating for her when she's mistreated, welcoming her friends and partners into the home, connecting her with LGBT role models. There was a very interesting study that asked heterosexual youth to draw their future and LGBT youth. And the heterosexual youth drew college, marriage, children, and the LGBT had blank pieces of paper. Because what happens is when they come out, they often lose their whole world. They are kicked out of the church, often are the church choir. They're kicked out of the Boy Scouts if they're Boy Scouts. Their friends fall away, except maybe for some. And we do have GSAs now in the middle and high schools, Gay Straight Alliances. And often they're homeless, they're kicked out of their homes. So it is a big deal to come out. So going on into teenagehood, again, alcohol continues to be an issue, and trying to find adequate treatment, sensitive treatment for your patients who want inpatient or outpatient treatment can be challenging, because usually this is small group work, and then there's a risk of coming out or not coming out to sometimes a judgmental group. A lot of lesbians use AA for recovery, but they usually use additional resources also. IPV, interpersonal violence, is about the same prevalence in lesbian couples as it is in heterosexual couples. And when you look back, 30 to 40% of lesbians have been involved in physically abusive relationships. This is kind of a specific lesbian definition of IPV, a pattern of violent behavior whereby a lesbian seeks to control her partner by controlling her thoughts, beliefs, or conduct of her partner to punish for resisting her control. The additional issue that can be brought with IPV in a lesbian relationship is threatening to out the victim to her employer, because usually there's no job protection, as well as to her friends and family, if she's in the closet. Janice Restock in Canada did some very interesting small groups and found out that the perpetrator is often older, similar to heterosexual IPV, and more powerful, but the actual role of the woman in the relationship can change. So a woman can be a perpetrator one relationship, the next relationship she may be the victim. And so it doesn't necessarily have to follow that she's already the perpetrator. And these are the psychological abuse aspects with IPV. Now this is the biggest public health problem I think lesbians face, which is smoking. And no matter what the study, there is an increased rate of lesbians who smoke. Whether it's the general California population, where it's about twice the norm for straight women, it's 28% versus 12%, or the Women's Health Initiative with an odds ratio of 2.58, or lesbian nurses in the Nurses' Health Study. And right now we're working on intervention programs because a lot of lesbians are too shy to go in for regular American Lung Cancer small group work. We're working on online programs, as well as at Lion Martin Clinic, which was mentioned, they have a group called The Last Drag. Pap smears for lesbians, we all are aware probably by now, but last week the guidelines did come out, and I'm very happy about them because they initially were about initiation of intercourse, and these are more generic about initiation of sexual activity, because lesbians do get cervical cancer. 90% of lesbians have had sex with men, but even when there's a cohort that Jean Marazzo follows, which are called lifelong lesbians, where they've never had sex with men, they still get cervical dysplasia and cervical cancer, and often related to the HPV. So lesbians do need pap smears, same schedule as heterosexual women, and that's really important because I've had lesbian patients write to me from different parts of the country saying that my doctor won't give me a pap smear even though I asked for it because they say I'm not sexually active with men. And these are the reasons for less pap smears in lesbians. Partner benefits are a big issue, even though there have been some more companies that now allow domestic partner benefits. The majority of companies don't, and so a lot of lesbians like medical insurance, and they often don't know where to get the pap smear. I'm just going to touch on mental health issues for lesbians. We know that depression is more common in lesbians, especially lesbians of color. They have the triple threat, being female, being of color, and being lesbians. They're more often in the closet, which is associated with more depression. Through the research of Liz Bruskin in California, we know that lesbians are more likely to use psychotherapy for depression rather than antidepressants, but of course both are effective in the treatment for depression. There is some resilience that needs to be studied in some lesbians, and one of the control groups that has now become popular to study lesbians are their sisters because they were raised in the same environment, and one study does reveal that there is higher self-esteem. This is a myth that lesbians don't need contraception, but it's also a challenge to create that trust with your patients to talk about birth control. And so the way I do it is that if someone's identified that they're sexually active with women, only I say, well, sometimes lesbians speak with their gay male friends or with their male friends, although mostly they have relationships with women. I just want to let you know that Plan B is available, or what are your plans if that happens to you. When we started Ryan Martin Clinic, the most common reason lesbians did not go back for care at that time was because birth control was pushed inappropriately on them. And actually, a young woman from Stanford who came to see me to talk about a class she had there told me that she'd seen a nurse practitioner in San Diego, and she went in and she filled out a questionnaire, and the nurse practitioner said, "Are you sexually active?" She said yes. "And are you using birth control?" She said no, and she launched into a lecture about how can you be so irresponsible, you're getting this great education, you know, you're going to get pregnant, and she just was totally intimidated and couldn't actually get it out that she actually was sexually active with women. And I'm encouraging her to go back and please educate her nurse practitioner so that she will continue to get good medical care. Probably half of lesbians have had some oral contraceptives, which is actually good because they're probably at an increased rate for ovarian and endometrial cancer, which contraceptives can help prevent later on in life because of increased body mass index and because most lesbians don't actually birth children. Talked about that. And I will continue with Dr. Kalakar's description today in terms of, we talked about lesbians can get HPV. I give my lesbian patients the same cautions as I do my heterosexual patients about genital herpes transmission. There have been anecdotal cases of discordant lesbian couples with HIV, with the HIV virus being transmitted between them, but that's very rare. And we do have, quote, safer sex kits that sometimes are given out, which has like dental dams, but the problem is dental dams have never been studied for porosity, and does the HIV virus actually go through there? We do have female condoms. One of our residents is just doing an internet study on how many lesbians actually use barrier protection with other women, and it's like 10% or less. They do if they have more than one partner. They do if they have concurrent male partners, but we don't even know what safer sex practices are for lesbians. We barely know what their sexual practices are. So it's hard for us to give counseling, but probably if you have a HIV discordant couple, you know, decrease sexual activity around the time of menses, decrease involvement with rectal sexual activities, maybe common sense, but we just don't have the research there. Chlamydia is a really important problem with lesbians. Not that it gets transmitted back and forth, but that actually the prevalence between ages 15 to 25 is higher than that of straight heterosexual women. And it is highly correlated with multiple partners, which includes some men. We know that chlamydia causes lots of infertility and chronic pelvic pain later. We are not being successful in screening every young woman from ages 15 to 25 every year with chlamydia cultures. But even if you have a patient who identifies as lesbian, please do her annual chlamydia culture. Gonorrhea, probably not really going back and forth between women, but not a lot of research. BV, I have another slide on, and Hep B has been transmitted between women. This is all in your references in the syllabus about the recent study about chlamydia and lesbians. Now, BV is controversial. We think maybe there's a concordance in a lesbian partner of 23%, but then there was another paper that balanced this out. We do know that increased number of sexual partners, including increased female partners, increases BV. It's associated with increased BV. We know that smoking, we know that vaginal penetration with fingers or sex toys without washing sex toys. And one thing probably we should be counseling our patients to have separate sex toys, or if you use sex toys, to use condoms. The actual rate of sexual dysfunction in heterosexual women is around 44%, so lesbians do have less sexual dysfunction than heterosexual women. However, we rarely have time in our 10-minute office visits to actually ask about sex, but sometimes patients do present with pelvic pain, and further questioning reveals sexual dysfunction, and it's important that we address this. I'm going to talk a little bit about reproductive options. We're having a baby boom in many parts of the United States. The most common choice by lesbians when they're ready to have a baby is insemination by a known or unknown donor. Often there is a choice at the time of buying the sperm from the sperm bank, whether you want disclosure at 18. A lot of young men don't read the forms very carefully and have marked that it's okay to contact them when the child is 18. And so the California Sperm Bank ran some nice focus groups to help prepare these men later on in their lives for that phone call where they may find they fathered children that they didn't realize they had marked the donor release box. And how does that first meeting take place so that everybody is less anxious about that. Some lesbians do have intercourse to become pregnant. That's the minority. And there is some selection by lesbian couples for something called co-maternity, or intra-partner gamete transfer is another word for it, where you have a lesbian couple and you do IVF and you take the egg from one member of the couple, you mix it with sperm, and then the other member of the couple carries it, so they both have a biologic connection to the child. About 16% of lesbians have given birth, and there are many ways for lesbians to become parents. And that with all women, we should be asking around the age of 30 for sure, whether they're heterosexual or lesbian women, what are your plans for having children in your life, if in fact that's something you are planning to do. We see so many disappointed women at age 40 thinking that now they're finally ready to get pregnant, and why aren't they pregnant after a couple of months of trying, not realizing that actual fertility starts to decrease in your 30s, and in your 40s you do have some technology, but it doesn't work all the time. Rarely do our worlds need to connect in terms of addressing legal issues with our patients, but I think this is one of the rare times where it's important. So if you have a patient saying, I'm planning to get pregnant next year, if she's in a relationship in particular, in a same-sex relationship, encourage her to seek legal counsel, because it really has a huge impact on her mental health and how she might raise her child, so that she knows the decisions that she's making. In most states, if she has a gay male friend who puts the sperm in her mailbox and if she self-inseminates at home, the male partner will have parental rights 50%. If it goes through the medical office, then it will be like formal insemination without rights unless if the proper forms have been signed. And we're having a lot of lesbian women now choose to co-parent with either gay men or straight men. So there's just many different aspects of it. It's important that your patients are aware of this as they set up this part of their lives. We know a lot about the children of lesbian couples. We know that by the mid-20s, there's no difference in sexual orientation, self-esteem, or emotional health. It's hard to calculate, but now with the new census data, being able to mark the box as to whom you live with, 1 to 6 million children in the U.S. are being raised by same-sex parents. And almost all the studies show the outcomes are the same, although there is more stigma experienced, especially during the high school years. And a meta-analysis at USC revealed the children to be less aggressive, more nurturing, more tolerant diversity, and a little more androgynous, a little more bisexuality in the early 20s that is usually disappears by the mid-20s. Quality of life of adolescents raised by lesbian mothers, the adolescents perceive it to be about the same. And the Annette Bertrell has done some really important research of following 85 lesbian parented families. The kids are now about 21 years old. And she found out there are actually less problems in adolescents than in heterosexual youth. Now we're into midlife. We know that lesbians do have an increased BMI, and people are trying to figure out why is that. Because we also know there are bigger health problems associated with increased BMIs. Theories are a possible greater acceptance of large body size in the lesbian community, all the lesbian potlucks, could be social induction of obesity among lesbians, which we do know in heterosexual couples when they get married there can be increased weight, and perhaps the rejection of a dominant culture's aesthetic. The exercise, the good news is lesbians exercise a little bit more than heterosexual women, but neither group exercises enough according to the guidelines. The barriers that were discovered in small groups had to do with just being embarrassed of being out if you join a lesbian softball league, it means that you're a lesbian and you may not be ready to come out to the rest of the lesbians or your family or whatever. Or feeling shy in the locker room, feeling that heterosexual women will be uncomfortable with you as a lesbian in a locker room, and certainly institutional barriers. Breast cancer in lesbians has been controversial. At one point, about 15 years ago, the word was out that breast cancer was 3 times as high in lesbians as heterosexual women, and that actually is not true. This being female, of course, is the risk factor, but actually it is slightly increased statistically for lesbians. And let's look at some of the risk factors for that. There's more smoking, more lesbians are nulliparous, and therefore have not breastfed. Although I have to make an aside here, Nanette Bartrell's data showed that the lesbians in her study met the American Academy of Pediatrics guidelines for breastfeeding for a year exclusively. I've never heard of another group reaching that guideline. I always wondered if there are really men on that committee who established that guideline because it's such a huge project, breastfeeding. Previous breast biopsy is associated with risk factor, obesity, current alcohol use, and past problems with alcohol. In terms of screening for breast cancer, most studies show that lesbians probably get mammograms as frequently as heterosexual women, kind of plus or minus. But one thing is for sure that lesbians were less likely to have had a clinical breast exam within 2 years, which we know can be important in picking up early breast cancer. Lesbians who are diagnosed with breast cancer have difficulty accessing breast cancer support groups for lesbians. Usually they're only available in urban areas, and often they're not very well funded. Those women who go to a heterosexual support group often find a lot of the discussion is about the man's attachment to a woman's breast rather than recovery, whereas heterosexual women are dealing with, their male partner's reaction to their mastectomy if they have a mastectomy. So that may not be the ideal support group for her to go to. We also know that for lesbians, there's a small study looking at breast reconstruction, and a lot of lesbians were not happy with having immediate breast reconstruction when they actually have a mastectomy. That needs to be studied more. Quality of life for breast cancer survivors and lesbians has been studied, and it's pretty equal to heterosexual women. We talked about durable health care power of attorney for lesbian couples when we take them to the operating room, but now we're getting toward end-of-life issues in terms of lesbian life cycle. And so few people, including everyone in our country, have really thought about end-of-life issues in terms of who's going to be their health power of attorney, do they have a living will, if they have a condition and the paramedics come to the house and there's a big major event, do they want to be resuscitated, and if they don't, how are they going to make that known to paramedics, or do they have their forms in one of these red vials of life that's taped to the refrigerator or taped to their bed? And this is very state specific. There's an interesting study this year about views on hospice and palliative care of lesbians versus heterosexual women, and it found that lesbians held significantly more positive beliefs about hospice and alternative medical care. And you also find a lot of lesbians in your practice are more likely to use alternative medicines and practices than heterosexual women, but overall about 40% of all of our patients are using complementary care now. And compared to heterosexual women wanting everything done, lesbian women weren't as enthusiastic if they had an incurable disease. The decision to enter hospice for lesbians can be actually quite complicated because they actually may be anxious about having to come out. And this is reflected also in the nursing home experiences of LGBT people. It's not unusual for LGBT people to go back into the closet when they have to go to a nursing home because there's a lot of abuse and a lot of fear on both sides when an LGBT person is in a nursing home. There's a really wonderful film called Silent Jen. If you ever have a chance to watch it, it's about a trans person end of life. I have a funny story from one of my nursing friends, which is an elderly friend went into a nursing home and her other friend hadn't seen her in a couple of years. And when she came to visit her, the patient her friend was just floundering around while they were trying to get her dressed. And they were explaining to her that every day they had this huge struggle to get this woman dressed. And the friend said, well, of course, she's never worn a dress before. Why are you all putting her in a dress? And so they started putting her in pants and everything was fine. But this woman, had in and out dementia, and they really didn't get to know her very well before she got there. Some lesbians are not out as to their life partner, and when they have the loss of a life partner, the grief can be very complicated. It's obviously complicated for anyone to lose their life partner, but if you're not actually having the social supports that are woven into you because people know that you've lost your life partner, that's extremely challenging. So that's just something to be aware of. So in summary, best practices: having a welcoming office, encourage disclosure, and it may not happen at the first visit. It may happen over a few visits. In fact, I had quote sisters who were like 70 years old in my practice for a while. I need to operate on one of them, and I knew they weren't sisters, but they felt more comfortable presenting themselves as sisters as opposed to a lesbian couple, because you're going to find generational differences in your practice. Also, a lot of your older lesbians are not going to be coming out to you, whereas out and proud young lesbians may be more prone to coming out to you. Make sure you're doing appropriate screening tests, you're doing pap smears, you're screening for substance use. There is increased substance use also, besides cigarettes in your lesbians. Make sure their preventive health measures are getting taken care of. We don't know anything about colon cancer, but possibly because of BMI, lesbians may be at increased risk for colon cancer. Talk about family planning early and often. Talk about healthcare decision paperwork. And it means a lot to your patients for you to be an ally and for you to get involved as a hospital and make sure that there's access for care for LGBT persons. So the next step is to go back to your offices after the conference and check your intake forms. See what choices there are for people to check. Educate your staff. You can take the syllabus and show them the syllabus and explain how important it is not to be judgmental at your front desk. And in fact, I always volunteer to do the final interviews for our front desk. That's the face of your practice. And I ask, well, do you have any experience with diversity? And diversity includes LGBT, and are you comfortable? Because I do have LGBT patients. And how they respond to that, it gives you very much an insight of how they might be. Make sure your reading materials in your waiting rooms are diverse and educational. Ask your patients about their sexual activity and orientation. Have resources available. The reference list is long so that you can use it, and I'm always available at UCSF for any challenges. And also be aware of workplace issues for your LGBT colleagues, because they're often marginalized. They can't talk about their weekends. Their partners are often uninvited to the chairs for dinner, et cetera, and they've often heard a lot of homophobic comments by colleagues, so they may not be out to you either. And by being open and supportive, you can make a huge difference in their lives also. You're the grassroots movement. You can make a big difference in the health outcomes of your lesbian patients. Thank you so much for getting up early and